Well, I am happy that I'm just after Isabel, because I think this presentation have two aspects. Is not going in detail for any specific aspects related to migrant health. You will see, even because many of these aspects we are going to be addressed today and tomorrow. What is to me, the added value of this presentation is, first of all, he will show to you what, let's say, have done the projects that were mentioned, for example, by Isabel Della Mata, because there are many projects going on dealing with migrants, migrant health in particular. Sorry, what? Hello. Hey. Sorry, maybe I should stay here nearby, and will be difficult for me. Anyway, the added value of this presentation will be to show to you what some projects have done for these issues related to migrant health. And the second one is putting let's say, the accent on how complex is this issue. Even if we are speaking about health of migrants, we cannot, let's say, forget about about many other aspects that are, let's say, having an impact of migrant health. And so, just reminding us that we should work in a really in a multidisciplinary way to approach what we want to reach. So, for this reason, you will see that I will touch mainly these points. The preparedness, the vaccination, of course, always related to migrants, monitoring migrant health, and dissemination on national public health portal. So, of course, we should get prepared to the migrants that are entering in our countries. And we saw, I was collaborating with one group before, that ad hoc syndromic surveillance may be, can be a good tool, especially when we want to really have an early warning system. We participate, we set up in Italy a syndromic surveillance system when there was a huge, let's say, flow of migrants after the Arab Spring. And we revised it in 2014 to improve the quality. You see, in the first sentence, there are two aspects very much discussed in the group and even connected with syndromic surveillance. We may want to address several uncertain and high-profile situations. We may have the need to reply to some issues, for example, not only to our boss, to the health system, but maybe also to the mass media, to say how is the situation, to reassure them on some aspect. So in that case, the syndromic surveillance could be really a good tool. Early warning and say something on what is going on. And then on the basis of what we've done in Italy, and also on the basis of other expert opinion and what was going on in Greece, we help, let's say, we prepare a manual guidance to help implementing syndromic surveillance in migrant reception detection center and other refugee settings. This is to say that really with the arriving of migrants, syndromic surveillance start to have a big role, not only in Italy and Greece, but even other countries ask European Union and so ECDC to have some technical documents. And then we care also, that was mentioned by Isabel Dalla Mata, that is a recent project. We also reinforce this concept of syndromic surveillance, working with some 5 countries in European Union. Okay, but this is for, I mean, syndromic surveillance is for the people coming. But how are our centers? Are they ready to receive them? And what should be assessed in order to say something if we are, sorry, what should I do? Out? This one, delete? I don't want to. Okay. So we may need to assess our capacity, to see if we are ready to receive, remember that we are in the preparedness phase, to receive migrants. And maybe we have not much resource, and we want to decide where to put our resource. We need to reinforce our human resource, medicine, vaccines, or our, let's say, physical structure. So we were asked to prepare a sort of checklist tool for ECDC, but for all the, of course, European countries and others that could use it, to understand which is the level of our preparedness in considering possible huge entrance of migrants. So I don't want to bother with this. If you are interested in understanding how you could assess, I mean, we can be in contact. The manual, of course, is available online. There is also a checklist, an Excel with a checklist where you can really rank, try to make your assessment. What I just want, let's say, is to call your attention on is that you have some objectives related to your assessment. For example, the first objective is outbreak prevention. So you want that your center are able to prevent outbreaks. And then let's assume that you have this outbreak. You want to be able to control it. But what is really interesting is, okay, this is in normal life. But if instead there is a larger sudden influx of migrants, let's say, am I able to cope with it? And if yes, what are the, let's say, critical aspects, the indicators that I mentioned here, that I have reinforced? For example, often human resources are the first point that we need to take in mind if we want to be ready to this influence. So, but not only preparedness. I mean, we should also imagine that the emergency will move to another kind of situation. And for this, what the figure that WHO prepared for during one meeting, workshop, was really nice, because they tried to put all the aspects that could help to improve and to take care of migrant health. And you see, they put, of course, monitoring, and we will see something, but they put also policy legal frameworks. Someone of you before mentioned what is, let's say, right to health. Here, maybe the laws can give the right of health to all in equal way, but is that also in terms of equity? If the migrants, they don't know that they can claim for that, or their services are not acceptable for them, is really a right there available? And for this, Also, the health system should be considered and were considered in this case, and also partnership networks in order to promote coordination, dialogue, cooperation, and so on. So this is to say that we try, I will report some actions that we did in order to try to address this aspect. For example, vaccination, so to increase, how to increase vaccination to reduce vaccine preventable disease. And as Isabel de la Mata said, our action went back to one project, EPISOUT project, where many of you in terms of countries were involved. And there we understand that, working with all the actors involved, that we should have look for accessibility. Migrants are really able to reach and use immunization service, and acceptability. Migrants' willingness to use immunization service is there, and contact coverage, contact with the migrants and the service providers. Otherwise, even if the entitlement is there, maybe you cannot succeed. And we assessed this with the survey, with all the 27 countries involved at the time in EPISOUT, EU and non-EU countries. And this was the basis for going ahead. Because the conclusion of the study say that alongside, that is 2007, so 2009 was done the study. Alongside policy to improve access to health service effort, both at national and regional level, need to be made to develop tools to assess and monitor vaccination coverage among migrants groups and to evaluate the impact of measures adopted to increase immunization service utilization. So we continue, I mean, we in terms of participation, and was mentioned again by Isabel Promovax, and seeing the situation in terms of immunization coverage, we described the situation with some 6-7 partners in European Union member states, and we described how was the situation in terms of access of immunization policies for migrants, and which were the migrants' culture and attitudes toward immunization. So finally, with this project, we identified that there should be some specific criteria, for example, in terms of defining a service, let's say, is accessible and acceptable for different kind of culture and migrants. And also in terms of vaccination delivering, we identified an index of best practice in accordance with some evaluation tool. And we, on the basis of these best practice, we provide some recommendation in order to, let's say, strengthen our immunization service in order to reach and to be open to migrants. Okay, but we understood also that trainings, I mean, enhancing capacity of health workers was really an issue. So we prepare, of course, some manuals, and we start with the project and with many colleagues, because, for example, the coordinator of this project was Prolepsis at this time. So we were working all together in network. We prepare guidance tool for health worker trainings and also educational material for training for migrants dealing with primary service, especially vaccination. Also, staff training were conceived, still with project mentioned by the European Union, CHAFEA, and here we start really going in detail because we have data on what was needed. So we go on sensitivity and awareness, on of cultural and other forms of diversity, knowledge about migrants, and so and so. But do you see how much is complex and how long was the process, and it still is? And we continue. We continue. There was another project, PROVAC-MED project, and in this case, we move in the Mediterranean and Black Sea area with many of the countries that are here. And again, we try to understand what was hampering the access to vaccination of migrants. And so we were seeing if there were specific law procedures, in which way these countries decide if to immunize the people coming in or not, and which kind of vaccination were used to newly arrived migrants. So we start to have an idea of what was going on that before was not available. And again, we try to see, I would say, the very same issues. I mean, immunization policy, capacity to involve the newly arrived migrants, even in some European countries with the CARE project. And this is available, of course, this outcome from CARE. And the nice thing are these country summary box, very short, but you can understand how these countries cope with immunization of targeting newly arrived migrants. Okay, but just, I mean, to go a step ahead and to conclude, I mean, now we know where we are. Most probably, in some countries also, the emergency phase, in the way that we considered before, we can say that is also past. So now is really the aspect to be considered is really how to monitor the migrant health, what we need. In particular, a recent report of WHO said that epidemiological surveillance capacity need to be strengthened to include migrant-sensitive data. Systems that collect data in respect of migrant health also need to be reinforced so that outcome and access issues may inform further planning around appropriate target interventions. So we are not anymore in the emergency phase with early warning needs and so on. We should be able to describe which is the situation in relation to migrants. So we should start to be able to say something in relation to the migrant population, no? And but in this case, we should consider that so far the variability among the migrant groups is not considered, and the data that we have are very incomplete. Moreover, there are many aspects that are, and some of them were already mentioned, that are hampering, that are misleading what we say about migrants. There is over misreporting of case of disease and disalignment with appropriate denominators. You know, we discuss in our group, denominators is still a problem. So, documented and undocumented immigrants tend to have limited access to healthcare and preventive service. So maybe you have underestimation of disease occurrence. And in other cases, instead, you have that both the accuracy and availability of denominators is, let's say, tends to have incomplete denominators that are increasing the population at risk. And so you have an overestimation, and so on. Moreover, we have to start to think that migrants are not only one population, migrants. The vulnerabilities are really shaping a sort of different groups and different kind of migrant, let's say, risk group. Because here, for example, you can start with migrant, something referring to migrant characteristics. So you have migrant definition, migrant status, and so on, and migrant trajectory, so their trip. And you are here. You are, let's say, issue very much related to the status of migrants. But then these migrants start to come on this line, let's say, and even other behavioral factors are adding value to his characteristic. So you have specific disease risk factor. You have specific protecting factor. You have something related to the mobility, origin of infections, risk, and protecting factor during travel. So our migrant is moving here, starting from his entrance, his or her entrance in our country, and his or her length of stay. And then even socioeconomic factors start to, let's say, to qualify the kind of migrants, and even demographic characteristics. And finally, their needs may overlap with indigenous population. So all this is not considered so far. We put migrants, but you know that now that we have, let's say, overcome the emergency period, in some countries these aspects start to emerge. So we really need to consider this in a way that we can really say something about our kind of population that is residing in our countries. And what we are able to say and to collect step by step should be also shared at national level. Because many times these information are gathered by international, let's say, collaboration, or by European project or not European project, and so on. It's very important to share what we understood from this project, working in network like we are here today, at national level. So, for example, in Italy, we have a space in our national portal that is dealing, I'm sorry, of course it's in Italian, because it's for the Italians, that are dealing with migrant health, and are explaining, for example, that really are not bringing all these infectious diseases that we were thinking before. And their fragilities many times overlap with our fragile population. Thank you very much.
Thank you. Just like to address your latter point about the need for better data and definitions for migration. I completely agree that that's a need. But I wonder if you could comment on how we balance that need with the increasing sensitivity politically around migration. I'm from the UK, where anti-immigrant sentiment is now so high that we've just voted ourselves out of the European Union. Obviously a stupid thing to do. We've got people now in the UK who are legally settled migrants, EU migrants, who don't want to disclose that they're from the EU because they're feeling politically sensitive about it. And I'm just thinking, if there are surveillance systems that become increasingly, and medical systems become increasingly, wanting to have more and more information, it could maybe be a disincentive to migrants accessing care, which would be shooting ourselves in the foot. So how do you balance the need for information with it being light touch enough that people will come to access healthcare?
Well, first of all, I think that it is going to be a long process because we work, for example, with ECDC. You know that they are collecting information from all the national systems, but so far it's very difficult to say something regarding migrant population. I mean, so what, for example, we propose in our documents that, of course, was requested by by CDC and by the Commission, is to insert very critical variables or indicators, as you prefer to call, that can really, I mean, describe what we need to know. I mean, what. So it's a matter, we identified not many indicators to be added to what we already sent, for example, to ECDC. The second point is that sometimes we collect this data. The problem is that many times when we saw all the database, the national database, the information are not interoperable, or are not, how you say that, not, I don't want to say homogeneous, but at least shareable, to comparable. So what I mean is we can compromise, because it's not a big effort. Is really to identify some 2-3 indicators that can help to to stratify, let's say, and to say something about the population. For example, before was mentioned the length of stay. That is really a very important determinant, an indicator, because I show you that according to the length of stay in the country, many things are going to change. We discuss also in terms of communicable disease or not communicable disease. And that is one indicator, length of stay. And there is not many ethical, let's say, issues behind. So I think that we can. She wants to integrate, maybe.
Okay. Then we have a question here.
Yeah, I just made some example also this morning in my presentation. Probably it's a long process that should come. So we need to start thinking that migrant variables are as other variables that we need for stratifying and understanding better a population that is particularly vulnerable and so on. So it's for better understanding. Sometimes the variables are there, but are not filled in or very badly filled in by the countries. Or, for example, we checked in Italy among 4 special enhanced surveillance, measles, legionella, meningitis, and others. We were collecting nationality, country of origin, all difference were country of origin, nationality, citizenship among our own country. So, because we were not used to do it, and probably something that we should start thinking about and see the best way to balance, to check the best indicator, because each of these variables has pitfall and strength and so on. So it's just, the message is just starting thinking, because we need, as we stratify for age, for sex, for gender and so on. So we need to understand, because there are different risk factors, drivers, and so on that come across the migration. And then when the people are in the country, they are more vulnerable than normal population, probably.
saying that his time is over. Is true? Is true?
Thanks for the very nice overview of all the work that you're doing. I attend quite some of these work groups with people from public health, and I often feel that we don't get any further than saying we need better data and we need more data. And I truly wonder if that's the case, if we need better data and true data, and that we're not stuck in a moment where actually we stop communicating very critically to our policymakers. And yes, there is a political tendency, but I also feel as public health specialists, which most of us are in this room, that we should also move the discussion like, okay, now we have all the data, so how do we move towards action? And I think, you know, like it comes kind of back to the question I tried to ask about the Libya deal and the Turkey deal. I mean, the fact that they don't do any monitoring of the health of the refugees that we actually send there should also, as a public health community, pose question marks here, saying, okay, our policymakers are doing something and it's very questionable. So let's also discuss this side. It's not just about science, and it's not just about generating data. And I think in the arena of public health, it's much more about that. And I hope that during the next days, we'll also focus a bit on this.
It's a comment, I think.
Yeah, I think it was. Okay, so thanks a lot, Maria Grazia. We will pass now to the next presentation.